So this is Jennifer James with my teaching presentation. I would like to start off with a disclaimer that I have been unable to actually present the presentation at my facility due to scheduling conflicts with availability of a room, as well as we do have an increased number of associates out with COVID at this time. We're kind of seeing an uptick there. But my presentation is on sepsis. So what is sepsis? Sepsis occurs when the body is trying to fight off an infection, and it causes immune chemicals to be released into the system. The release of these immune chemicals triggers an inflammatory reaction. It is a systemic inflammatory reaction which does deprive the organs of oxygen as well as nutrients. And with the deprivation of the oxygen and nutrients to the organs, it can cause multi-systemic organ failure. In 2016, the CDC really started looking at sepsis and what does that mean? What does that look like? What should the treatment be? And how many lives can be saved by really treating early recognition and treatment of sepsis. So what are your at-risk populations? That's going to be your elderly, your children, and your infants. People over the age of 65 fall into that elderly category, as well as people with comorbidities, especially diabetes, cancer, and liver disease. People who have immunocompromised systems, whether it's from chemo, from HIV, from organ transplant, that population is at very high risk for developing sepsis. And then of course you have the recent surgical procedures along with indwelling devices that can be catheters, med ports, that can be fistulas, even anything that is accessed multiple times or allows for an opening into the body that bacteria can be introduced through. Excuse me. Some symptoms, signs and symptoms of sepsis. This is very important. So there's an acronym of FAITH. So if you can remember: fever, altered mental status, infection, a known or suspected source of infection, people with those indwelling devices, recent surgical procedures, anything like that is a suspected source of infection. And then tachycardia and tachypnea, hypotension, hypoxia, and hypothermia. We think of people with an infection having a fever, but that's not always the case. Sometimes once the body starts to decompensate, they actually become hypotensive and hypothermic. So if you just remember to keep faith, you can save lives. So diagnosis that frequently lead to sepsis. Actually, pneumonia is the #1 diagnosis that leads to sepsis, along with urinary tract infections, respiratory, GI. Those symptoms, systems actually can lead to sepsis. In my experience, these are 3 frequently missed diagnoses that can lead to sepsis, but we want to say they have a urinary tract infection. We don't want to go ahead and cross over into urosepsis. They have pneumonia, but we don't want to cross into sepsis. And endocarditis actually does account for 1% of the patients diagnosed with sepsis. So we just need to remember, whenever we're dealing with patients with these issues, you just have to be cognizant and monitor those lab results, monitor the patient's condition, make sure that if they tip over into sepsis, that we are recognizing that and treating that timely and effectively. So what is the treatment for sepsis? The two things that have the most impact is to give crystalloid fluids at 30 mils per kg. Now we do have the patients, the CHF patients, the dialysis patients, and we always feel a little afraid to give those fluids, but they need it. They need that volume expansion to kind of help them get over the hump. We can always remove the fluid, but they need that initial treatment. And the fluid should be infused within the first 3 hours of recognition of sepsis. And then broad spectrum antibiotics. So we don't know what it is yet. Of course, we're going to have labs on all of these patients, and blood cultures and urine cultures are very important for that. But until those results come back, if you cover with a broad spectrum antibiotic, then you will be covering the majority of the bacteria that could be causing the infection. And the antibiotics should be given within the first hour of recognition of sepsis. So this is from a patient's perspective. This is a very good little short video that we're gonna see from a patient's perspective.
On Friday, the 1st of August 2014, 59-year-old Jeremy Thompson from Bournemouth was rushed to the Royal Bournemouth Hospital Emergency Department with a severe urinary tract infection. In pain, short of breath, and passing blood in his urine, Jeremy's condition was already extremely uncomfortable. It was also about to get worse.
I was been very poorly for a few weeks at home, and I decided not to go to work that week and went to the doctors. And he said to me, "Oh, you have an infection," gave me antibiotics, which didn't really work, and I was passing blood. And by the end of that week, I'd collapsed, and my wife called an ambulance, and I went to Bournemouth A&E.
When Jeremy arrived at the Royal Bournemouth Hospital, he was feeling pretty awful, but for the first 6 hours of his admission, his condition was stable.
Whilst Jeremy was in A&E, he was treated really, really well, and I felt that they had everything under control.
Jeremy was reviewed by a senior doctor during the morning Saturday ward round on the 2nd of August, and his notes were left that he needed monitoring, but there was nothing to indicate significant cause for alarm or urgent action. This comes a few hours later at 10:30 a.m. Jeremy's vital signs at this time show he is seriously at risk. His breathing is shallow and rapid. He is suffering rigors, a temperature of 39, a pulse rate of 130, and a respiratory rate of 32. His vital pack chart shows that he has an early warning score of 8, so Jeremy is going downhill rapidly at this stage.
With signs like this, sepsis should have been suspected immediately and urgent action taken. But in Jeremy's case, it wasn't.
I arrived at 2 and was quite shocked to see how he deteriorated from when he was in A&E. And at one stage, Jeremy said to me, "Should I be on intravenous drugs and fluids?" And I said, "Well, I don't know, I'll go and find out for you." Went to the nurse's station and they said, yeah, of course he should be on the drugs. And I said, "Well, he isn't." Half an hour later, he still hadn't been put on his intravenous fluids and drugs. It took 3, I won't say moans, but I had to go and sort of keep saying to him, "Can you come and put him on fluids?" We were told how important it was. When he was finally put on the fluids and the drugs, he then kept saying he felt sick. He just felt like the pain was 8 out of 10, 9 out of 10. He was definitely getting worse. I voiced my concerns to probably 3 nurses, but one in particular, who just kept saying that she knew what she was doing and he was fine, he was fine. I got really concerned when they were giving him more and more morphine, and he became much calmer, said that the pain wasn't as bad, but it was like he was just going into a deep sleep. And I thought, he's dying. You're not listening to me. What I'm telling you is that if Jeremy's saying the pain is now 10 out of 10, and he's now gone very, very quiet, this is not Jeremy. And once again, I was told that they knew what they were doing and he was fine and there was no need to worry. And yeah, so from that moment on, I felt that he was fighting for his life, and that was something that should never ever have happened. It should never have got to that stage.
So what we have here is a situation where a patient is not only showing numerous red flags, but his wife is also extremely concerned and making those concerns known to our staff, but nothing is happening. I think a key moral of this story is to trust your instincts. If your patient is showing red flags in the vital pack and or their relative is extremely worried, it is critical to escalate. Don't wait.
At 6 p.m, 8 hours after Jeremy began to dangerously deteriorate, a worried member of staff took action and called for direct support from the Trust's outreach team. Specialist nurse Mark Knight responded.
Took one look at Jeremy to know that this gentleman needed urgent attention fast. my every instinct told me this was severe sepsis. His vital signs backed this up. His wife Linda was beside herself with worry, repeatedly telling me how unusual this was for a husband to be so ill. We transferred Jeremy rapidly to the intensive care unit, where he was given antibiotics, high flow oxygen and drugs to maintain his blood pressure.
So then I was taken to intensive care. Well, I was sedated, I suppose, and unconscious, and taken for this and that. But the strange thing is I could hear everything. And then I was brought out, whether I was asleep or in intensive care, whatever they do, and they tell me I'm sepsis and they've got to do this and do that. So I left intensive care, was taken to a ward, which, in my opinion, was a safe haven, because I had just gone from somewhere that was bizarrely intense, and then now I'm in this with other people, and I thought, this is better, I must be getting better. But I was very poorly, and Linda and the nurses adjusted to my lifestyle then, because I was moved in for 5 months or more. And then I got moved to a side room, which was fine, but then because of the volume of things that had to be done to me, it was 24 hours. I would be woken up at 3 in the morning, 2 in the morning, and so forth. I was told I wouldn't be going to work again. And so Linda and I had no income coming in, and we had to manage our home still. I think it was harder for Linda because she had to go home to no one. At least I was in a hospital with lots of people.
Jeremy is still with us, but had that phone call come any later, I feel he would have deteriorated further and possibly had a cardiac arrest. My advice to any member of staff in this situation is trust your instincts, look at patients' vital signs, and listen to loved ones and escalate early. The medical and surgical teams would rather hear about 100 patients who do not require critical care input if it prevented a further situation like this occurring in the future.
Though sepsis didn't kill Jeremy, his life will never be the same.
Even when I was in intensive care, I was conscious of Linda and I financially struggling because I'm self-employed, so is Linda. And I think one of the things I said to her when I woke up was, have we sold our house? And she said, no, and I was conscious of that. And it's a year on and I can still only work so many hours a week. We do have problems for surviving, but we will survive. So you can survive in your life, you can survive financially.
It took a concerned member of staff 1 minute to call outreach with their concerns. But that member of staff's call and Mark Knight's fast review saved Jeremy Thompson's life.
When I was in intensive care, I couldn't remember much. But I owe Mark my life. I can say thank you, but
Because Mark listened and you acted, that was the thing. So many people shouldn't end up with sepsis or severe sepsis. It should never ever get to this stage, I don't feel.
Will your next patient survive sepsis? It's in your hands.
it didn't start out well, but it got better, and it got better and better.
So he's a lucky one, he survived it. We just wanted to make sure that doctors and nurses were aware of what can happen if you become complacent. That every patient is an individual, every patient has hopefully a family member or someone, and you have to listen to them. They're a help, not a hindrance.
So that's very impactful. That is from a patient as well as a family member. So listen to your patients. They know their bodies. They know what's going on. Listen to the family members, and you can see the impact that it has had on this patient and the family member, their well-being and their livelihood, whenever it could have possibly been avoided should someone have listened. So that video really spoke to me. You know, we get so busy and get so task oriented that sometimes we do kind of forget to listen. So just as nurses, listen to your patients. And to go along with that, just so this kind of hits home, is hospitalized patients with sepsis have a 75% longer length of stay. So you heard in the video how he talked about it was months that he was in the hospital fighting for his life part of the time to be able to get past the sepsis. The mortality rate for sepsis is 20 to 30%. That's why it is so important for us to recognize early, take action early to get those fluids and those antibiotics on board. There are approximately 270,000 deaths per year in the United States alone just from sepsis. So these numbers are big and they're very impactful. So what can we do here at Cabrini? What is it that we do? So if you remember FACE, fever, altered mental status, a known source or suspected source of infection, we call a code sepsis overhead. If we call a code sepsis at our hospital, we're going to have rapid response nurses going to respond. We're going to have nurses that are specifically trained to know what to do for sepsis, the labs to order to make sure the fluids are given. So we're going to have all of those people that come to help notify the provider and ensure that he or she uses the sepsis order set. That order set does include all of the labs, all of the things that need to be done, everything that needs to be monitored. Without using that order set, we will fall out on being able to make sure that critical things are done for the patient. Ensure the fluids and antibiotics are administered timely. Remember, 3 hours to get the 30 mils per kg in 1 hour. 1 hour of noticing that a patient has crossed that line into sepsis. That first hour is imperative to get those antibiotics on board. And then of course you're going to monitor your patient's condition. So are there any questions? Remember, a great question doesn't simply inform, it enlightens. And I want all of you to be enlightened on sepsis. I want you to feel more confident and comfortable to use your expertise, to listen to the patient, listen to the family members. If you think it, call a code sepsis. If you think it, notify the doctor. It's not going to hurt a thing in the world, but if we do catch it in time, then we can save lives. Thank you.